Welcome to this explainer. If you're an anesthesiology resident gearing up for your boards, or you're just looking for some high-yield clinical rounds, well, you are exactly where you need to be. Today we're taking a dense stack of clinical notes on orthopedic and trauma anesthesia and transforming it into a really focused visual learning experience. We're going to break down the critical pathophysiologies, those absolute must-know cutoffs, and the life-saving protocols you're going to need when you're the one sitting at the head of the bed.
Okay, let's dive into this. Here is our roadmap for today. 1. Systemic ortho risks from cements to clots. 2. Joint specifics focusing on hips and shoulders. 3. Trauma basics covering airway and resuscitation. 4. Neurotrauma looking at TBI and spinal cords. And 5. Burn management and fluid resuscitation.
Round 1. Ortho risks. Cements to clots, where we're managing systemic complications right there in the OR.
Let's anchor this with a quick clinical vignette. Picture this scenario. You're in the OR, right? Your patient is undergoing a total hip arthroplasty, and the surgeon is prepping to insert that femoral prosthesis. Then suddenly the alarms start blaring. Your patient's oxygen saturation literally plummets, their blood pressure drops completely out, and your ECG is showing a sinus arrest. So what exactly is happening here? You have to diagnose this intraoperative crisis instantly.
The answer? Bone Cement Implantation Syndrome, or BCIS. Now, this is an absolutely critical high-yield mechanism you've got to understand. When surgeons use polymethyl mecrolite, bone cement, it actually undergoes an exothermic reaction. It gets super hot, it expands, and the intramedullary pressure inside that bone can suddenly exceed 500 millimeters of mercury. That is a massive amount of pressure, and it essentially forces fat, bone marrow, air, and even the cement directly into the venous channels. At the exact same time, systemic absorption of the cement monomer causes this massive vasodilation. Your treatment here? You want to get them on 100% oxygen before cementing, maintain euvolemia, and absolutely make sure you're communicating with the surgical team to vent the femur.
Let's move on to another major systemic risk, marked by a very specific number, and that is 72. If your patient has suffered a long bone or a pelvic fracture, you've got to be on high alert for Fat Embolism Syndrome. But why 72? Well, because the classic clinical presentation of Fat Embolism Syndrome typically rears its head within 72 hours of that initial fracture. The fatty acids essentially damage the capillary alveolar membranes, which then triggers this whole cascade of vasoactive substances.
And this brilliantly illustrates why this is so tricky, because there's no single definitive lab test for Fat Embolism Syndrome. Instead, we have to rely on Gurd's criteria. You're looking for the classic triad of major criteria: respiratory insufficiency, cerebral involvement causing confusion, and a petechial rash. To actually make the diagnosis, you need at least 2 of those major criteria, or 1 major and 4 minor criteria, things like tachycardia or a sudden unexpected drop in platelets.
Now, because orthopedic patients are at such a sky-high risk for deep vein thrombosis and pulmonary embolism, they're very often on anticoagulants. And hey, neuraxial anesthesia is fantastic for these patients. It actually helps reduce thromboembolic complications by increasing venous blood flow. But here is the vital number you absolutely must memorize for your boards and your everyday practice on the wards: 10 to 12. If your patient is on low molecular weight heparin, you literally must wait 10 to 12 hours after their last dose before performing an neuraxial block. Otherwise, you're risking absolutely devastating epidural hematomas. No shortcuts here.
Moving right along to round 2, joint specifics, hips and shoulders, navigating unique joint positioning and regional anesthesia.
Okay, so if you're doing shoulder surgery, the surgeon will more than likely want the patient in the beach chair position. But here's why this matters to us. Sitting a patient upright under anesthesia significantly lowers their cerebral perfusion. If you don't actively account for this hydrostatic gradient, the results can be catastrophic. We're talking severe morbidity here: stroke, blindness, or even brain death. You absolutely must ensure your blood pressure transducer is leveled at the brainstem, specifically the external auditory meatus, and not at the heart. That is the only way to guarantee you're actually perfusing the brain.
As you can see on this slide, for shoulder surgeries, an ultrasound-guided interscalene brachial plexus block is pretty much your gold standard for post-operative pain management. Placing a peritoneal catheter right here allows for a continuous infusion of a dilute local anesthetic, and the payoff is huge. This provides excellent pain relief for up to 48 to 72 hours, which drastically reduces the need for systemic opioids and really helps facilitate early physical therapy.
All right, shifting gears completely. Round 3, trauma basics, airway and resuscitation. It's time to navigate the emergency shift.
Keep in mind, the moment you step into the trauma bay, we have to make some immediate life-saving assumptions. Assume full stomachs and assume cervical spine injuries right off the bat.
Now, what's really interesting about this slide is how it breaks down hemorrhage. As the anesthesiologist, you need to clinically stage hemorrhage instantly so you can guide your fluid response. Take a look at class 1 and 2, that's blood loss up to about 30%. At this stage, the patient is compensating with their sympathetic drive. Tachycardia is going to be your very first clue. But once you hit class 3, 30 to 40% blood loss, that compensation fails. The blood pressure drops. This is your critical inflection point where IV crystalloids are simply no longer enough and you must initiate blood transfusions. By the time you reach class 4, over 40% blood loss, you're facing severe hypotension and total cardiovascular collapse.
So how do we actually predict who needs a massive transfusion before they completely code? Well, we use the rapid-fire ABC score. It's based on 4 key factors. Is it a penetrating mechanism of injury? Is the systolic blood pressure less than 90? Is the heart rate 120 or higher? And lastly, is there a positive fast ultrasound exam? A score of 2 or higher means it is time to pull the trigger on your massive transfusion protocol. You need to initiate damage control resuscitation right away with a balanced 1:1:1 ratio of packed red blood cells, fresh frozen plasma, and platelets. That's how we combat trauma-induced coagulopathy.
Up next, round 4, neurotrauma, TBI and spinal cords. We're focusing heavily on protecting the central nervous system and preventing those secondary brain injuries caused by hypoxia or hypotension.
These numbers right here, these are your holy grail for managing traumatic brain injury. And let me tell you, they are highly testable board material. You must maintain the cerebral perfusion pressure, or CPP, between 50 and 70 millimeters of mercury. And simultaneously, you got to keep the intracranial pressure, the ICP, below 20 millimeters of mercury. If you slip up and let the patient become hypotensive, hypoxemic, or hypercapnic, you're going to cause cerebral vasodilation, and that drastically increases cerebral edema and ICP, which is a fast track toward driving the patient into brain herniation.
Let's move over to spinal cord injuries and see exactly how this builds on that whole concept of perfusion. For years, there was a ton of debate about how to manage acute cord compression, but today, the clinical consensus is crystal clear. Ensuring robust spinal cord perfusion by maintaining a supernormal mean arterial pressure, or MAP, is currently considered far more beneficial than administering high-dose steroids like methylprednisolone, which really has limited evidence of efficacy anyway. So your absolute priority here is aggressive blood pressure support.
All right, our final round, round 5, burn management and fluid resuscitation. Let's look at the unique altering hemodynamics in thermal injury. So the crucial point is really understanding this concept of burn shock in patients with major burns, and we define that as second or third degree burns covering more than 20% of their total body surface area. They experience a systemic inflammatory response unlike anything else. I mean, within just 30 minutes, massive vasoconstriction causes their cardiac output to plummet by up to 50%. This is profound normovolemic hypoperfusion. Because of this, immediate, aggressive fluid resuscitation isn't just supportive care, it is absolutely life-saving. And to calculate those life-saving fluids, we usually contrast the 2 major resuscitation guidelines, the traditional Parkland protocol, which runs at 4 ml per kg per percent burned, versus the modified Brook protocol, sitting at 2 ml per kg per percent burned. Now, while the actual volume formulas differ, notice what they both agree on. They both strongly prioritize crystalloids, specifically lactated ringers. You really want to avoid large volumes of normal saline because that causes hyperchloremic acidosis, and you definitely want to avoid hypertonic saline, which significantly increases the risk of acute kidney failure in these extremely vulnerable patients.
And here it is, our final critical clinical cutoff for this explainer, the number 48. This represents a vital 48-hour window for airway management in burn victims. You see, burns cause a massive upregulation of extrajunctional acetylcholine receptors at the neuromuscular junction over time.
Which brings us to this provocative clinical scenario. Imagine it's 3 days post-burn, your patient deteriorates, and they desperately need an airway. Is it safe to secure it with succinylcholine? The answer is a definitive, absolute no. Activating those newly upregulated receptors will trigger a massive potassium release, causing fatal hyperkalemia and immediate cardiac arrest. It's a really stark reminder of how trauma fundamentally rewires the body's baseline physiology. The everyday drugs you rely on can suddenly become lethal. So as you step into the OR, you always have to ask yourself, are you just treating the injury right in front of you, or are you actually prepared for the massive physiological cascade hiding just beneath the surface?